Good to be here with you, Fred.
And everybody, we're 6 feet apart.
Socially appropriately distant.
Oh dear. Well, what have you been doing to keep yourself busy while you're locked up?
That is, are we out of cabin fever on a very beautiful day when it's for the first time actually above 70? Was it last week? I got the message that I was on the run and I heard it through the phones in my ears that this was the first in recorded time here that it hadn't reached 52 degrees for May 10, I think it was, or whatever the date was.
All I know, I had to go cover up all the plants I put in.
So I think this is something that's right in the middle of your strike zone, and that is the times they are a-changing.
Oh, yes.
How is it that we never had this before, and this seems to happen all the time? So change does seem to happen,
Yeah.
and change happens in such a way that is not consistent in a pattern that we can recognize, and therefore someone must be responsible for this. Someone's at fault for whatever this is. They're starting to use internal combustion engines, or we're shooting off rockets instead of bows and arrows, or a couple of other things like that. Yes, I think the changes have happened before the internal combustion engine and before the bows and arrows, for that matter.
Yes, oh yeah, and they're still going on.
Celestial events. So when we plead to the heavens, what's happening? There are some of those heavens that respond, actually, and send us meteors and some things that are called, what is the Maunder minimum, for example?
Oh yeah.
Explain that.
Right, and the Helmholtz cycles, and it's all to do with the orbits of the sun and how close it
Sunspots
is.
and
Or the orbits of the Earth, should I say, not the sun.
and intermittent events that we can now at least predict to some degree, but didn't have that capacity earlier in history, and of course not in prehistory. And that is a passage of certain comets of the kind that come in showers that are with a bunch of asteroids and other space things.
Well, believe it or not, after I finished writing my book on climate change, I decided to keep going just to sort of keep up to date with all the stuff that's going on. And unfortunately, there's so much going on that it's almost been impossible to keep up with.
With lots of variables, there's a little hard time to put one on the ordinate here and one on the abscissa, I think.
The research is incredibly good today. I still can't get over how advanced it's become.
One of the things that's a problem that results from that, and I always say it's an instance in which the precision outweighs the accuracy.
Yes, it's definitely happened several times.
We can measure things with such an exquisite precision that we start to think that that must be the operative component that's giving us the change in fact. So I find that to be a bit disturbing, because we can do this precisely in multiple areas, and now which outweighs the other is a judgment question. We haven't got the
What a
wisdom.
lovely non-sequitur.
I have another non sequitur which doesn't sound political. I mean, it might to some, but the question I would raise to myself, being a very proud Yankee doodle all the way through, and I have my little blue passport, so recognize that first of all, my loyalty oath. Second is, how's this America First worked out for you? We now happen to be America First, all right. America, that which is the single most advanced, at least economically, and some would have said politically, and not that many would have said culturally, is now the leader in the world for a communicable disease? Come on, didn't we conquer all that? Didn't we? The conquest of infectious disease was one of the hallmarks that entered us into this modern era. So no longer are we subject to the next sneeze from the next door neighbor, or someone who passes us on the running trail within 6 feet, or someone who is sitting in the back of the bus, or any of the other component parts that we had said, well, we're over that now. Yeah. And now the big surge in the market for hand sanitizer and environmental surface decontaminants, and some are suggesting we inhale them or spray them and put them in veins, all of which means we are confusing the antimicrobial properties of an antibiotic with that of an antiseptic. And so we ought to straighten this out in some way and say, how can America not be first? Well, we've achieved a first that's rather unenviable.
Oh, man.
88,000 deaths, 1,456,000 cases, and still one of the laggards in testing and contact tracing and all of that. Meaning, we've lost some of our public health on the basis of our curative expertise. Remember, I said this once, I think, in our conversations together, that when I was earlier in another pandemic that we had no knowledge of, it was sort of a sustained ambiguity. I would walk back and forth from my office on Pennsylvania Avenue into George Washington University, and there'd be these cement barriers, and there'd be a stenciled, sprayed, painted sign. ACT UP is watching you. We demand an AIDS vaccine. And I thought, well, I understand the urgency and the desperation from which that had sprung, that a group of people were saying, we want to be freed of this, so we'll find a cure for it. I would have responded, again, with sympathy, but at the same time with some accuracy. We have penicillin, therefore we have no gonorrhea. Meaning that with an effective cure for something, it relieves you of all the burden of living responsibly. Now, I don't mean by that I want to change the behavior of a group of people who have some convictions of one type or another, but behavior change is necessary. And it turns out that the LGBTQ community has been quite responsible about this. Take, in contrast, the ultimate act of anti-socialism. The most antisocial act I can imagine is make the world go away and stick something into your vein such that suddenly the whole society around you is obliterated. That's the antisocial act that makes these people very susceptible to that kind of communicable disease.
You raise so many questions in what you're saying right now that I find one of the most amazing things for me is that having now reached, I think it's 7 books, and the research for all of them, I now think I've turned into being a damned historian. Because, there's a whale of a difference between, talking about the current deal
Scientist, Lord save us.
having had time to digest what really happened. That's when you get the right perspective.
That is an important thing because, in fact, in medicine, as I have gone through primitive to modern in multiple cultures, the first question asked is always, why? Why me? How come?
Right.
Who sinned? Who cursed?
Yeah.
What fault? And then eventually we get away from the why to the question of how. How did this, where's the agent? Robert Koch helped us with that. Robert Koch's postulate said, here's the agent, with it you have the disease, without it you don't, and when you take the agent you can make the disease. However, once we focus on that, get a cure for the agent, we still haven't solved the fundamental question, why?
Put another way, what you're really asking is, is this a near-term or a short-term problem? And I look from a historic point of view and saying, look, it's going on right now, so you can't really write about it sensibly. A historian, I wonder what they're going to think, say, 100 years from now about this. What are they going to say and think? Did we underreact or did we overreact? Did we twiddle our thumbs when we should be acting? But to me, based on my general research that I've been doing, I'd say that's not the question we're asking. It's why did we lose control over some of the very key elements that are so important that we no longer dictate, the answer. Other people are doing that work.
We get very effective in a micro focus, losing the macro perspective.
Right.
And in fact, I think there's one, I'll give you one that's most current right now. We need a cure for COVID-19. We got to have it. It's going to be a vaccine or a drug, and we got to get it. We got to have it right now. So a multi-center trial was used for a failed drug, and the failed drug was designed in order to combat the Ebola crisis, and of course it was dropped because there was no benefit whatsoever. In fact, it made some of them worse, and that's why it was dropped.
Right.
Now this remdesivir comes back, and given to a number of patients, it turns out, does it change the mortality of COVID-19? And the answer is we can't get there from here. We don't have enough time, we don't have enough patients to make that determination. But wait a minute, we see that there is a change in 60% of the patients to the time of those who survive the disease to discharge. It's 4 days shorter. 14 days for the group that didn't get the drug, 10 days for the people who get the drug. So let's say it's a success. We now have to give that drug to everyone and not to anyone. Wait a minute, you're telling me they shut down the world's largest economy and all the other economies around the globe in order to shorten hospitalization time? That didn't answer the question. The question is, was it important enough as a disease that would kill people, that would change the mortality of this disease? Now that's a research question. But then let me ask a bigger question and a higher one. All these other things that are taking up so many people's time. We don't have enough masks. I need masks. Give me 5 million masks today. And you can order General Motors to make 250,000 more ventilators. A ventilator, remember, isn't treating the disease. It's trying to buy some time for something else to happen in that interval if that time is of value. Well, if nothing else is of value, that is, you have no disease treatment options, that time doesn't really matter much. An anesthetized patient who's paralyzed on a ventilator in an intensive care unit, I would say, is probably not what we would consider productive human time. So the answer to that question, I believe, is, once again, why? Why did this patient get this disease? Why is it that this disease came out through a whole society that was previously not at risk for it? How is it that we have such a huge difference among populations? For example, Iran is just decimated. Iraq, not touched. Why Dominican Republic is really not Haiti next door? Why Ecuador, a disaster? Why Argentina? It can't be because of their governments, because many of these, the ones I work at least, are failed states.
Yeah, right.
So the government doesn't have that much influence in it.
What's the answer?
So the question is that, I think this is I can only cite our nearby sage of medicine in Johns Hopkins University, and I think I posed this once before for you. It sounds a bit Kennedy-esque, but that is, ask not what kind of disease this patient has, what kind of patient has this disease? So if you have a bunch of people, let's say young children, in a playground who have no concept of why not to hug their neighbor and why not to beat them over the head with their Orphan Annie doll or whatever it is, they seem not to have the effect for the disease that we as adults do. And what have we accumulated that has made us more susceptible to the disease? So for that reason, we have to ask again, why does this disease enter this economy at this time? Especially those places that are quite affluent, those places that are highly technologically successful. Well, perhaps it's because we can keep people alive long enough. No, that doesn't change the incidence.
Well, the historian in me is screaming some questions.
Let's hear one of those screams.
One of my screams would immediately be, with all of this going on, why did we choose to lose control over some of the most important things that we have in our lives?
Those would be political questions, wouldn't they?
Well, not necessarily, because the politicians can only do what they have the support from the populace is.
I believe you're correct there, but what you're saying is that the decision to live wisely on your part came from, number one, a certain amount of information that was validated. Number two, a certain amount of willpower to carry that through.
Well, I'm a World War II baby,
exactly.
Growing up.
The greatest generation.
Yeah.
And the third would be a capacity to do that. If we take the requirements for your basic nutrition and your exercise and your freedoms and all that sort of thing from the criteria of what would be satisfying. So yes, I think that's possible. Then there are people who have no capacity to do that. They don't have information, or it's incomplete, or it's contrary on the basis of some other cultural norms. It might be, I mean, for example, in the whole of industrial era England, we had people coming off of the farms and coming into the cities and crowding into tenements where they spent that 8 hours of the day that they weren't at their looms coughing at each other and working 14-hour days. And this is the Charles Dickensian England. Of course, something would fall into that niche. Now, it happened to be Mycobacterium tuberculosis. If we had control of that, before that, there was another mycobacterium where the serfs were affected and had to work very hard, and the soil didn't get the right nutrition, and they became the unclean, the lepers who were not allowed close to us because they were said to be contagious. Now remember, I worked half a century with Mycobacterium leprae and haven't contracted it. And the reason is I wasn't as disadvantaged as those serfs or those tenement laborers.
Well, I would concede the history, but if we look at the present and you say, okay, here's meant to be the world's greatest country where we elect to put medicine and care so low down on our priority list that we don't have the capability to handle something like this. Whereas a lot of countries, like say for example Sweden, has built up a great system with a size that can cope with today's problems.
Can I say the same thing on the other side of the coin, that we value individual freedoms and rights at a greater degree than we do the collective, and that the coercion that comes from all of us must do the following in order that the public good be improved.
Let me jump in.
Yes.
Why would we export a lot of these responsibilities to foreign lands a long way away that may have different opinions and ideals than we do? And so when we hit a problem, we say, we don't have any capability in our country. We've given it away to somebody else. And sure, we maybe have saved a little money, but we run into a problem and it's a disaster. I mean, look at testing. I mean, that would be a fundamental of any control system. I don't care what you're talking about.
You need to know and identify what is out there.
And, you know, what happened to our testing system? Why don't we have the capability to create testing?
I will answer that as one of those who doesn't disagree with you. Right. Now I will say, on the other end of that, nobody had the capacity to test for this because this is a novel coronavirus. No one ever saw it before.
I concede that. But still, I'm talking about testing as being part, sort of finding out how to do it with a new problem. But that's all part of what I'm talking about. It's not just, do we have the test kits sitting around to cope with a disease we've never had? I mean, that's obvious we don't.
And the biggest problem is in a nation state that devised CRISPR, it devised all of the chain reaction PCRs, it devised all of those. So in other words, it wasn't for lack of the basic science that we would say, it was the basic science was there. But there was no real threat to us because after all, we had curative care.
Right.
We have ICUs. We have 150,000 ventilators, all of which are in use. At the same time, 150,000 more are being produced. And I find that a historic number too. If you will, let me ask from a prior example in history, what this prehistory will tell you about what's coming next. I was taken by the chairman of our pediatrics department in the University of Michigan Medical School. Bless their hearts, I just watched their commencement on the virtual screen today. A very sad sort where every one of them is sitting at home and saying, "You are now MD and congratulations," without any family within 6 feet at least. And saying that to a whole lot of people. When I was a senior 53 years ago, on this very same day.
Oh, we don't use numbers here on age.
Okay, a bit more than half a century ago.
Oh no, that's not even worse. half a century. My
We had an
God.
11-floor hospital, the first university hospital in the United States, owned by a medical school. And we only had 10 floors of patients, and I was active on each of those floors and going through all my rotations. But our chairman of pediatrics was quite well known. In his last year, he was retiring that year. And a group of us that were called the honors group, about 3 or 4, but we actually, I figured out, selected out for special tortures, had been brought to have individual conversations with a number of the people around at a little better, or let's say more advanced level, where the answers weren't apparent before the questions were asked. And he took us to the elevator, and with a key, we went up the elevator, passing the 10th floor, which was our limit, to the 11th floor. And the 11th floor opened up, and it was all dark, and as we opened that up, it kind of had a musty smell. And I looked into the 11th floor, and it was a bit spooky. I think it looked like the last scenes in Star Wars, or no, the Ark of the Covenant was put away. In the
Oh yes,
right.
right. I love that scene.
There it is with all these racks and rows of things. And in the middle, there were a couple hundred sheets over things that looked a bit like the morgue, and this was very spooky. And Dr. Nelson, who was very famous because of Nelson's Pediatrics, his textbook, said, "You, Geelhoed, come over here." And I did, and he pulled the sheet. He said, "You know what this is? An engineer named Cecil Drinker had devised this. And here, I'll open the lid, take off your shoes. I want you to get in this." And so I did. And so he puts the baffle and the bellows around my neck, and I'm looking at a mirror so I can see him while I'm lying on my back there. And the mirror is adjustable from the outside, not the inside. And he said, "Okay, now we're going to close the lid." And we flip the switch here, and a little electric bellows pump starts. And the whole tank goes negative, and then it goes positive. So first you fight it a little bit, and then eventually you decide, well, hey, wait, I might as well ride it. So you just sort of relax a little bit. Now you're being breathed by Cecil Drinker's iron lung.
Oh my God.
There were 100 or more in this 11th floor, all in storage, because of course there had been no need for them because of the polio campaign, which, by the way, is one of the diseases that we are attempting to eradicate, which of course is another subject that we can get into about the arrogance and ignorance of eradicating another form of life, because that might not be successful. And it hasn't been in this instance either. There were 29 cases reported in 2019. The 2 places that they were reported were because of political suspicions.
Oh, I read about that.
One of those is an area in northern Nigeria where I worked, where Boko Haram said they're coming here to sterilize us, and that's what those polio surveillance teams are here to vaccine, sterilize us. So they want to spread the religion by the sword and eschew public health and the system of polio inoculation. Second one is in an area of Pakistan where the polio surveillance team looked around and said, "Have you seen any children with this flaccid lower motor neuron paralysis? And what's in that building over there with the high fence and the guardrails?" And then they left, and that was the end of Osama bin Laden. And so, as a consequence, the 2 sites where polio vaccine did not penetrate is in northern Nigeria, the Boko Haram, and in Pakistan, around the area where we last had the Osama bin Laden drew his last breath. So as a consequence, there's probably a legitimate political reason for them thinking that, and that's kept that disease from being eradicated. In my lifetime, as a child there, I got late the Cox vaccine after the Sabin vaccine, the difference between the killed virus and the live attenuated virus, and the threats that it eliminated family members of mine. That is, there were people who had actually died during the summer polio season when we weren't allowed to go to the swimming pools and things like that because of that fear. So I'm looking now at this experience, and I'll tell you what terrified me at the time, and then what my thoughts are a half century later. At the time he said, "Well now, is that getting easier for you?" I said, "Yeah." And he said, well, experience this because not too many people will be able to do that now in the future. And he flipped the light switch and said, we'll be back after lunch. So I was in the dark on my own for an hour and 20 minutes. I knew that from the time we went in, and I looked when I was out much later. And there was a bit of a panic there for the moment because I could either continue fighting it or just ride it and not know how that was going to turn out.
You obviously don't suffer from claustrophobia.
So now, here I am, and I'm going to ask this next question. Having experienced that then, with what is halfway technology now obsolete, where will that museum be where these 300,000 ventilators will be stored? The 150,000 we had, the 150,000 that General Motors had been ordered by the Chief of State to be produced, when in fact he never did order the production of 150,000 new intensivists.
I'm wondering if the historians will label that a political maneuver that had no place in trying to get the facts out. But I would argue that, look, if we aren't prepared and we aren't geared up to do something like this against this virus, then we deserve some political mistakes because they're going to play to the crowds.
Oh, there's a short-term bias for every political one. Let me give you another one, and I'm an indirect beneficiary of this. And that is when I was coming down from Boston, where I learned two things that were techniques that were brand new and no one had done them in Washington. I brought them with me to Washington. One of those was you can ventilate the lungs, but the lungs are the things that aren't working, like everything else was, and you ought to rest the injured part.
Right.
So we had a new thing that was available, and it was called a membrane lung. Blood circulated on one side and the oxygenated atmosphere on the other side. So this was called ECMO, extracorporeal membrane oxygenation.
We have that?
We do indeed.
Good
And
heavens.
in fact, now it is being applied to some of those patients who have ventilator failures here.
Yeah, I would think so.
Number two, I was a student of, and the special mentor relationship I have with him, of a fellow who turned out to be a very close friend. As I arrived at Harvard, I had been so bold as to be in the front row of the Peter Brigham's grand rounds and raised the question about a single patient that we had treated who was history's third liver transplant. And after
up your street.
all the people had talked and everyone had given all of the data, the chief of the infectious disease stood up and said that he had Tommy Gorence, the fellow's name, which is now public, so it's not a course of violence of his confidence. In his brief lifetime in our intensive care unit, had 457 blood cultures drawn, all but 2 of them positive. The next fellow stands up and as the hepatologist says, Tommy Gorence died with a bilirubin of 1.0, which is normal. So one thing was working. And the next stood up, and then finally, as the bone to the boy, they tossed this to me, since I was the one who was chained into that room for the period of his life during his ICU stay. They said, and now, Dr. Geelhoed, remember that was a title that was recently attained, do you have a comment? And I said, you've just heard all the clinical commentary. But I went to the business office and I asked our fellow there, and he has told me that Tommy Gorence's hospitalization of 47 days cost the entirety of the health, education, and welfare budget of the Federal Republic of Nigeria, from which I have just come, a nation of 128 million souls. And I said, there was not another word said. I thought, uh-oh, my career at Harvard has come to an end. And everyone filed out, and Joe Murray with his long white coat comes over, looks me in the eye, and he says, you know, you're right. Let's come and talk. from that point on, he was my mentor, my father figure. And we talked a
Wow.
lot. He was the one who, after I left, and after that period of time, I got a opportunity to work here at NIH, and several things were happening to me, and he made a trip down just to say hello and find out how I was doing. I said, "You must be on your way somewhere." "No, I came down to see you." And the next meeting I had with him was also in that somewhat casual way. I was attending the American College of Surgeons Clinical Congress in San Francisco, one of the first ones that I'd done. After that, I attended each one each year. And I'm walking through the exhibit hall, and across the way comes Dr. Joseph Murray, and he ran over to see me, put my hand, "How are you doing? Wanted to hear how your last trip has gone. Tell me about those patients. I'd love to accompany you, but my wife Bobby says, 'Now, Joseph, you have to have respect for the calendar.'" And he said, "I just wanted to ask," and then a number of people crowded around us, and they all wanted to talk to him too. So I backed away, and as I backed away, there's the high gain antennas on the trucks outside, and they're all, I said, "What's all this?" He said, "You didn't know? Joe Murray just got the Nobel Prize for being
Oh my goodness.
the first one to transplant a kidney." Well, so that was Joe Murray, my mentor. I wrote a Festschrift article, and he, first of all, didn't want the honors of having a whole journal dedicated to him, but then he said he would agree to it if mine were the first article, because he said the one thing he wanted always throughout his life was to go with me on a mission, and his wife had interdicted that. Now, to give you that story is not for the sake of that story alone, and the reason I mention the story, to add one other sub-story, is that I was in the closet next to room 2 in the Peter Brigham operating room, and there's a bunch of stuff also with sheets over them, and I took the sheets off from one of them, and they said, "What's this?" "Well, that's a bunch of stuff that's going to get thrown out." And, "Well, what is this?" And we pulled it out, and it was a series of chicken wire with some cellophane gathered around it, and a little pump, a roller pump with some tubing. And unbeknownst to me at that moment, but I knew it was something precious, so instead of having it thrown out, I took it over to my crowded, cramped little apartment at Harvard Avenue in Cambridge. And I had brought that with me to the Smithsonian, because that's Willem Kolff's first dialysis machine.
Oh,
And he had come from Nazi-occupied Holland, Willem Kolff, and with his religion and his interests, he had escaped, came to Boston, and so there I worked with Willem Kolff, the successors to him, never having done more than just meet him, because he wasn't active at the time. And I worked closely with Philip Drinker, Cecil Drinker's son, the inventor of the iron lung, and it was with him that I worked on ECMO. And that's the two things that I brought to Washington, D.C. were ECMO and transplantation. I did the first transplant in Washington, D.C. Well, here's the reason for the series of stories, because I didn't want to talk about this as ancient history, but as current ones. And that is, as I arrived here, there was not very much in the way of end-stage renal disease in the patient census, because people developed end-stage renal disease and died.
Yeah, right.
But there was another fellow here who was in Washington, D.C., not at George Washington University, but at Georgetown. His name was George Schreiner. He was an internal medicine doctor and became what eventually would be called a nephrologist. And he was involved in this process of using Willem Kolff's idea of dialysis and making a shunt. And a fellow named Scribner designed a little plastic shunt that went into the artery and into the vein, and it shunted around, it went through there. And then that was developed largely with VA research money in Washington, D.C. And George Schreiner took a fellow who was on dialysis. He admitted them to Georgetown every day because there was no outpatient dialysis. Admit them in the morning, discharge them in the evening after dialyzing them. Brought it to the floor of the U.S. Congress and hooked him to the Kolff coil and said, okay, gentlemen, see, this is a simple process developed in the USA with US dollars. And now we are going to clamp the shunt and we will send him home. And now he is your problem, not mine. That was ESR1, House HR1 that year. And that is HR1 was the first bill always introduced. It had been for the creation of a military medical school until the fellow who was the advocate of that happened to have been shot in a street mugging in Washington, and so he didn't get it in that year. And HR1 was ESRD, end-stage renal disease, 37 words long, which said, for the purposes of Social Security, all patients with end-stage renal disease are considered disabled. Those 37 words became 100 volumes of regs, but that established that if you have end-stage renal disease, you're a beneficiary of the federal treasury. Now, I give you this for 2 or 3 reasons, one of which is the patient doesn't know where the kidneys or the lungs are, or don't know the difference between the two, some of them, and if you have failure in your kidneys, you're a beneficiary of the federal treasury. You fail in your lungs, that's your problem, or your liver, or your heart, or whatever. Now, here's that question I posed to you after perhaps giving anecdotes that are longer than the question. And that is, end-stage renal disease was halfway technology. I always hear people refer to it erroneously as kidney dialysis. It doesn't dialyze the kidneys. People don't even have kidneys in some instances. They've been removed, or they're little nubbins because they're scars. So what it is doing is buying time for something curative, or better, preventive. And that ECMO, the extracorporeal membrane oxygenator, doesn't cure any disease. It buys time until something of value to restore the lungs. And I did it in 2 reasons. One was end-stage lung disease could be solved by lung transplant. So if you have a dialysis equivalent, meaning patients held on dialysis until a kidney becomes available, now you put the kidney in, now you take them off the dialysis. Good. Now how about the lung? Lung becomes available, you transplant that, you can take them off the ECMO. In my instance, we were worried about another disease that came along and it affected the lungs just almost identically to the current coronavirus. It's not a inflammation inside the lung that you cough up in sputum. It's an interstitial problem. Mine was pneumocystis carinii pneumonia. I brought an interest back from Africa because it was a property of starving children and very, very malnourished people. I created such at NIH by giving them chemotherapy, and I especially created them by immunosuppressing them for transplantation purposes. So we treated people with ECMO because there was a treatment for it. Curiously enough, a very old-fashioned treatment called heavy metal. I mean, I feel a little bit like an alchemist, right? They were giving mercury for things and lead and other things like that. This one was antimony.
Oh my goodness.
And an antimonial, at the time we given something called pentamidine, which we'd inject into the... Now, here's a patient on ECMO. We don't have a tube in their lungs because ventilated lung wasn't any good. And they are aware of this. The injection hurts, causes a little sterile abscess. But they were smiling because they knew that at least this was going to complete the eradication of that infection. And that several of these patients were able to come off the ECMO. Now, I say that because we don't have a treatment yet. There is no treatment, let's say it out loud. Remdesivir appears to decrease hospitalization time of those who would have survived. It doesn't change mortality. And we don't have a vaccine. Now, all of these things I've just described, because we've talked about ventilators, talked about masks, we've talked about hand sanitizers, anything else like that. If I have a mask, doesn't that mean I can be a little more reckless? I don't have to stay 6 feet away from you? If I have anti-malarial, doesn't that mean I don't need long sleeves and I don't need a bed net to sleep under at night? So, in other words, some of the wisdom of living wisely is relieved by the availability of a transplant. I gave you the one anecdote I remember because it was the only time I've ever written to a celebrity, and that was Larry Hagan. of Dallas fame,
Oh gosh.
who hardened his liver. And he said, yeah, I had a pretty good life. Yeah, look, liver got another one, but it's going bad now. I'll get a new one. And I wrote to him, you bastard, did you think that grew on a tree? Because, you know, someone died for your new liver to avoid your having to change your behavior. So what are we looking at here? If I told you 30 years ago, maybe 50 years ago, a new plague is coming to America. And the plague is that of 55-year-old white male executives who fall over after clutching their chest.
Okay.
And that was, in fact, an epidemic. And the answer to that is we're waiting for the drug. We're waiting for the single bullet. No, we don't have that single bullet drug. So let's replumb the arteries. Let's go around there. First of all, let's take the internal mammary artery and tunnel it in there, called the Weinberg procedure. No, let's anastomose it directly. No, let's take a vein from the leg and put it there and channel it. All of it halfway technology. It didn't treat the disease. You're treating a systemic disease with a focal procedure to bypass, waiting for something else. Now, the coronary artery problem of myocardial infarction has had a decrease in incidence over time. And was it cardiac surgical procedures, which were at one time the #1 operation performed in any hospital, also the most expensive? No, it had to do with a behavioral change. Now your likelihood of dying in Washington, D.C. is being struck by a passing motorist while you're jogging during your evening instead of going to dinner. So in other words, exercise, diet, and behavioral changes have made a greater impact on the epidemic of the 50s and 60s than did medicine and surgery together. Now I ask you once again, coming back around, this coronavirus that's now got more than the whole of the Vietnam War and twice as many as the traffic fatalities every year. And it's only in 3 months. So what happens now? We're looking for a cure, so then we don't need to worry about the diabetes and the under-exercise and over saturated fat. All of these other component parts that are the comorbidities from which people die. And coming around now, once again, I am in Africa, in the middle of Marsabit, which is the most remote and poorest county in Kenya. And a woman there whose husband died of this wasting disease, she never knew a name for it, but he's no longer here. And she has several children and they're dependent on her, so she gives them to her sister and comes down to Kibera, which is the largest slum in Nairobi. And there she sets up as what is now called commercial sex worker. And of course, there's a virus that enters that. Before that, there's a bacterium. Before that, there's a treponeme. I mean, syphilis, gonorrhea, hepatitis, everything is there, some of which we have treatment. We can treat the gonorrhea. We can treat the syphilis. But the one we don't have treatment for is HIV, which now comes wiping out a great number of that population. Not all of it transmitted sexually, some of it transmitted vertically, meaning from mother to child. We've got a new viral particle there. Suppose, as those activists were insisting, we get a vaccine or a treatment for this one viral particle, which, by the way, we have neither. We have no cure for HIV. We have no vaccine for HIV. And that's been debated for much longer time than the immediacy for the coronavirus. And we go out and give that to that woman and all of her fellow sex workers in that Kibera slum. But we leave that niche open. That social disruption has not changed. Something else will fall into that niche, and it will be guaranteed that it will be something for which we have no treatment, right? Because after all, we can treat the others and get rid of it and no focus on that social problem. So that the niche remains open. If those industrial workers were still in sweatshops, if the serfs that were worked to death in feudal Europe were there, and along came the bubonic plague that happened to affect that group that was in a major dislocation because of that societal stratification. If today we're talking about what has this coronavirus showed us more than anything else, it's not what kind of disease is this, what kind of patient got this disease. It turns out they're all disenfranchised, they're all comorbidly ill. So now, why do you want a cure for this disease? When in fact, there is no treatment for any disease that decreases its incidence. And in many instances, the disease increases with the availability of a cure. I can be casual about all of the things that brought it on because there's a cure for it.
You know, you're raising enough philosophical issues and ethics issues that all I can say is the one successful area we seem to have is justice. In that, you know, you have that lovely expression, justice is blind, where you have to take our emotions out of it.
Correct.
I think we have to do the same with medicine.
You're asking about rationing?
No, I'm proposing that medicine, it's been on my hobby horse for many, many years. I believe medicine should be a public service, and I don't think there should be a price to it. And so I've always been a supporter, even though it failed of, say, the national health system in the UK, but it failed for the wrong reasons. It didn't fail because it was a bad concept. And, you know, how do you put a price on life?
I have a feeling about the National Health Service, which is as yours, with a couple of exceptions. It started from the Labor government as a consumer benefit, and I believe that it is. Meaning that in the United Kingdom, should you have a problem, you will get good care at a reasonable price, with the following exception, which binds another.
And that's terrible.
And that is the queue, and because it started as a social service, and now it's run to the convenience of the provider. And so what it has been is that there's someone out in Bangladesh and somebody out in Malaysia and there's somebody longing to get the education that they can do in London, and they come with the idea they're going to hang a plate on Harley Street and go into the private practice of medicine there, and not knowing that they haven't a prayer of a chance. But for the next 20 years, they are indentured servants to the National Health Service. So the next biggest defect in the National Health Service is enormous professional disaffection by those who are actually doing it. And I don't know, you've recognized all around you the heroes and the accolades spread for the frontliners. The Blue Angels and the Thunderbirds are flying right down the Potomac, and I sent you that little clip showing it coming over to George Washington University Hospital, going over to Georgetown University Hospital. We applaud your work getting out there and risking your lives and that of your family for the benefit of another. Essentially, for no treatment. You're not treating the disease, you're trying to manage, maintain life long enough for something to happen. That something has to be, at the moment, your own resistance, your own immune response. Is there something we can do to augment that? Yeah, we're working on that. A vaccine. Then the question, who gets the vaccine? Well, certainly not Ecuador. They didn't help develop it. Certainly not Argentina. They don't need it. They seem to have done pretty well with their containment from their identification and tracing. So it would be, well, we own it because we paid for it and we developed it. Well, no, wait a minute. So you are asking the question, what price innovation and at what commodification can we use healthcare? And I have two thoughts on that from the provider side and from the consumer side. I agree with you. I don't want to be standing waiting when I can't breathe and the ICU is full and there's 2 ventilators. At the present time, there are 2 ventilators not in use at George Washington University. The next 2 patients will saturate that. There are 17 patients in the ICU. I'm not spilling private information because I haven't given you their names. 17 patients in the ICU, 15 of those are on a ventilator. Meaning
Wow.
the 2 extra ones on the beds are not yet taken and will be by the end of the night, I can assure you. So the question isn't that. In other words, we haven't been overwhelmed. We're this close to it, but we haven't been overwhelmed. The healthcare industry has not collapsed under the pressure presently here, as it did in Lombardy, which was every bit as good as we are, and in the United Kingdom, the National Health Service, at least from the bottom up, as good as we. What has meant this is that now you and I go down there together tonight, and those 2 are occupied, and they say, sorry, Fred, you know, you've had a pretty good life. And this guy Geelhoed with you, you know, he's come along the same direction, and he's made 78% of that century. And why don't you 2 toddle back home and not bother? So Americans don't tolerate the loss of a named life.
Oh, in the UK they do, because
Rational.
Boris Johnson, their Prime Minister, he gets infected, and what do you know? He's over 60, which is their limit.
Yes.
I mean, in the UK, to have a system that says when you reach 60, you no longer get treatment, I find that unbelievable.
Well, you've just identified it, that a named individual.
Yeah.
And so when I was a little kid, you weren't a bratty little kid the way I was. You did
Oh no,
what
I was a bratty kid.
You did what your mother told you to. And my mother told me to eat my peas because they were poor, starving children. And then she would name China, but that was too long ago. Then Biafra, then Ethiopia, then you name whatever the famine was at the time of your childhood. And then you as a bratty little kid would say, yeah, name 3. If I can't name them, they don't exist. So one of my jobs actually is to name them. My job is to put identification to those people that are starving for lack of these things. Now, then the question is, my mobile surgical units have 2 ventilators, 1 on each operating table. Were that known generally, you can believe it would be opened up with a can opener and those 2 extracted and put in the Prime Minister's office and maybe the head of state.
Right.
As a backup security on the basis of the fact that that's not a public good, that's mine. You know, I'll need to have that. But then, where's the expertise? Who's going to intubate? Not only that, where's the ICU? I mean, where's the care unit? Not intensive care. There's no overnight nursing. There's maternity, overnight, childhood beds.
Yeah.
So, in essence, it's
It's a flawed system.
when I'm there, they say you must teach these people how to intubate and to care for this coming onslaught of this enormous surge that's going to occur to them. Well, yeah, I know that Chinese curse very well. I intubate them, and now 24/7 till death do us part. They are my immediate responsibility because there is no other care. There's a lot of interested demonstration going on, but nothing of the care sort. So now, what they have said is, we want to be American. We want to be profligate. We want to have redundant capacity to care for all things. At the same time, that's for my benefit. But now bring that woman out of Kibera and toddle her over here. No way. I mean, she doesn't have an insurance scheme. She doesn't have any of the other things that go into this. I need to have those last 2 beds that I just described to you. Of our 17 beds there, you know, I want one available for you and for me. And don't tell me the door's closed, because my taxes and the other things. And besides, I'm insured. And besides that, I have money besides that. So what it is I can purchase that which I want and not just what I need. So now, the most favored, remember this is an Australian who used to write this down, probably the most intelligent referral I've ever had. He doesn't say, check into this and get the following tests and then take a look at this and then do that. No. 3 words. Do the needful. And so
Profound.
that is what I think we ought to do in healthcare. Do the needful. So, do we have enough ventilators? Well, we didn't have enough ventilators for this unexpected new novel coronavirus pandemic. Is it necessary? Yes. If you can't breathe, you need a ventilator to help that minimal marginal benefit. Is it sufficient? No, it is not, because we need a treatment for the lungs until they improve in order to take over so you can get the ventilator off. So in essence, everyone we put on the ventilator has a 1 in 5 chance of coming off. So you just told me that you have a guaranteed 80% money-losing, life-losing, morbidity-assuring mortality not changed. Is that the kind of redundancy you want to pay for with your next insurance premium?
Yes.
All right, so then you are among the exceptions in the world, and you are a typical American. Being another one of the same. So what you've just said is that you and I are willing to pay for redundant idle capacity. Now, downtown, we've got exhausted teams, and everybody is now distributing free food from whatever brand you've got, and free anything to just keep them on the job, on the treadmill, keep them going. But wouldn't it be nicer if we had 3 times as many and had 8-hour shifts and rotate them? Do you want those 2/3 of the workforce idled?
Oh boy, you now get into the ethics of it. You have to at some point back off and let things happen.
Well, it's happening, and it's happening big time.
It is, and this is one of the issues that I think the historians are going to grab onto and say, you know, what is happening to our ethics in this world? And you know this, I know, but a lot of people don't. Is, you know, one of the things that Christianity could always be proud of was its emphasis on ethics. You know, the 7 deadly sins was a classic, which were tabulated by that lonely monk out in the Libyan desert.
Yes, I love him dearly.
Which, you know, I mean, considering that was, what, 30 years after Christ's death?
He was a monument to wisdom, and St. Augustine was also funny. He could take himself not seriously, and he was right. I love it.
You know, the very fact that Christianity was the messenger of ethics, and you say to yourself, what is happening in this world? Well, we know damn well that Christianity has sort of been suffering. And when we think of, when I was a kid growing up, you know, in our community, I'd say 90% went to church. Today, you'd be lucky to say 9%. So it's been an incredible change in my lifetime.
What you just said about mortal and venial sins.
But the thing that nobody seems to understand is that Christianity was not just a religion. It was the only vehicle we had that fought for ethics. So now you'd say, okay, let's go into our political system, where back in the time of our founding fathers, you know, everybody was a Christian or of some religion. And yet today, you know, a few go to church, but whether it's for political purposes or not, I don't want to even get into that discussion. But today, our politicians represent the same percentage as the rest of the population. They aren't really going to practice as Christians. So they don't have any sense of ethics. So suddenly you have a political body with no ethics. You can see what's going to happen. And it's happening with, you know, and you come to your sort of area of you know, very, very important, probably the most important we have. I can't think of anything that's more important except maybe a military if you're being attacked. But, you know, given that, I can't think of anything more important. And we say to ourselves, my God, we got no ethics in this country anymore? Or nobody saying this is how we should behave or how we should judge ourselves? That's terrifying. And I'm not sure what history is going to say about this.